Now, this slide, this section is not intended to be like a comprehensive review of all the nutritional literatures around nutrient deficiencies and their relationship with blood pressure, but I just wanted to show you a couple of things. So here in this particular case, this is on vitamin D. It's a systematic review meta-analysis of studies on vitamin D, and the conclusion is the meta-analysis of the epidemiological studies disclosed that serum vitamin D concentrations are inversely related to the risk of high blood pressure, HTN is hypertension, in adults in a dose-response manner in both prospective cohort and cross-sectional studies. What does that mean? The lower your vitamin D, the greater your risk of developing high blood pressure. The higher your vitamin D, the less risk of developing high blood pressure. So again, major review on vitamin D. I think vitamin D is very critical for several reasons, and one of the side effects of vitamin D, the healthy side effects of vitamin D, is that it increases calcium absorption, right? So no vitamin D, you don't get good calcium absorption. What did we say a minute ago about calcium? It's one of the electrolytes that regulates the contractility of your blood vessels. So if you don't have enough of it, it's a double whammy. And this is one of the reasons why vitamin D is so critical, because it plays a role not just in and of itself, but also with the calcium. I pulled this from the website of Mount Sinai, which is a major medical hospital system. And so this was just on their own website. Now, I always like to take, especially from mainstream hospital systems, when they're saying it, it's a problem, because usually they won't say it. And so in this case, they were saying it, but this is about CoQ10. And it's interesting, I share a little anecdotal story with you about CoQ10. Let's read this first. But in one analysis, after reviewing 12 clinical studies, researchers concluded that CoQ10 has the potential to lower systolic blood pressure. Systolic is that top number, by up to 17 points, 17 millimeters per mercury, and diastolic blood pressure by 10 millimeters of mercury without significant side effects. So again, here's a substance in research that can lower your top number by up to 17 points, your bottom number by up to 10 points without any side effects. So why aren't doctors pulling for this first? Why aren't doctors testing for CoQ10 deficiency on a regular basis? It just doesn't happen across the board accurately, even though this therapeutic, CoQ10, has the potential to dramatically reduce blood pressure without side effects. And then we have this from Science, and that's blood pressure and nutrient intake in the U.S. And so this is just a major analysis that showed significant decreases in the consumption of calcium, potassium, vitamin A, and vitamin C were identified as the nutritional factors that distinguished hypertensive from normotensive subjects. In other words, people that ate less foods that contain, or people that ate foods that contain less calcium, potassium, vitamin A, and vitamin C were identified as people that were more likely to have high blood pressure. And then they go on to say lower calcium intake was the most consistent factor in hypertension and high blood pressure individuals. Across the population, higher intakes of calcium, potassium, and get this, I really want to put a circle here, because everybody always hears about sodium being so bad for you, right? But here's what they find is that low calcium, potassium, and sodium were associated with lower mean systolic blood pressure and lower absolute risk of hypertension, meaning that you got to eat enough sodium. And we've gone away from that. And what is the mainstream mantra with blood pressure? It's reduce salt, right? Well, what is salt? Salt is sodium. And so doctors nowadays, this is what they say, and they don't clarify. We need salt. Like, salt is super important. You don't want to not have salt in your diet. Now, the difference is if you're eating all processed food, if you're on a processed food diet, you understand that you're not really getting real salt. You're getting, you're getting chemically manipulated salt, predominantly in the form of monosodium glutamate, which is not the same thing as salt. You can eat nice pink Himalayan or pink salt. You can take in nice sea salt, perfectly fine, perfectly healthy. But when you're eating all those processed junk foods, what you're getting is this MSG, and this is a big part of what's going to elevate your blood pressure. And one of the reasons why that glutamate aspect of MSG is actually an excitotoxin. So it stimulates the sympathetic nervous system and turns it up, ramps it up. But it's not salt. that causes high blood pressure. Salt does help your kidneys retain water, but it's important, right? If you have good balance of potassium and sodium, magnesium and calcium, then your kidneys will retain the right amount of water without holding on to so much that it leads to elevations in pressure. But it's important that you understand that salt is a critical part of regulating your electrolyte balance as well. Now, I want to talk a little bit about the corruption in the numbers of blood pressure. I think it's important to draw a couple of things to your attention. So before we dive into these papers here, let's talk a little bit about, I'm going to move them out of the way. Let's talk about a little bit about what it means to have high blood pressure. So for those of you that may or may not know, right, systolic is the top number and diastolic is the bottom number. So generally when doctor says your blood pressure, for example, is 120 over 80, that 120 would be the top, that diastolic would be the 80, right, the bottom number. And what's the difference between systolic and diastolic? Systolic is the quantity of pressure on your vascular tree when your heart is not at rest, right? When your heart is contracting, versus the diastolic is your heart at rest. And that's why the numbers are different. One of the pressures is while the muscle's contracted, the other is when it's at rest. And so the number that we're most concerned about as it relates to like dangerous blood pressure is really this one. This one is harder to change. It's harder to change acutely, meaning for example, this number is going to stay relatively the same, that bottom number. This top number is going to change quite acutely. So like if you were to do 10 jumping jacks, your top number on your blood pressure would go up just like that. It would go up very fast, right? So the diastolic doesn't change quickly. The systolic can change very, very quickly, but it should also recover quickly. So like if you were doing exercise and it went up, it should recover relatively quickly if you sat down. Now, systolic over diastolic, again, this is how your doctor's measuring your blood pressure in how they're thinking about it. Now, the range for systolic is supposed to be 100 to 140. This is what the range has been. It's been this way for years, although recently, in the last couple of decades, there have been some changes in these numbers, and there have been a creation of something called prehypertension, which we'll talk about in a minute. The diastolic numbers, the normal range is between 60 and 90, right? So if you fall, again, going back 20 years ago, if you would have fallen within this range on your top number and within this range on your bottom number, your doctor would have said, hey, you know what? You don't have a problem. We don't need to medicate you, or you don't need to eat right and exercise, right? Your pressure's fine. Now, there are caveats to this. For example, let's say that your blood pressure, as long as you've measured it, has always been 120. And then on the top, and always been 80 on the bottom. And then one day you go to your doctor's office, and all of a sudden it's different, right? It started to change. Now that top is reading more like 135, and that bottom's reading like 88, okay? Now that would fall within the range of normal. Again, it wouldn't be your normal because you have a history of something much lower than that. So then the question should be by your doctor to you, what is different in your life? What has changed? That is driving this up, and there should be an investigation into that why. So again, there's nuance to this. But what's happened in the last number of years, and this was reported in the newspaper. So you see the title of this is New Blood Pressure Guidelines Pay Off for Drug Companies. And I commend the reporter for actually writing an article, because this is really hard. This is hard to do nowadays with so much, all the censorship that we've been getting. But it was when the invention of prehypertension happened here, right? And this was 2005 when this originally happened. So again, we're going back almost 20 years, but so what happened? There were different panels that were getting together, okay, to reclassify the reference range for blood pressure. So again, that reference range is 100 to 140 and 60 to 90 on the bottom. So what happened, behind each of those panels were the giant pharmaceutical companies that manufacture the new and expensive high blood pressure drugs. Okay, so in May 2003, for example, a National Institute of Health panel recommended broader use of hypertension drugs at lower blood pressures. 9 of the 11 authors of the guidelines had ties to the drug companies. That means there were 11 doctors, 9 of them had ties to the drug company, meaning financial ties. They were being paid, meaning they had conflict of interest or bias as it related to, they should, in my opinion, they should never have been allowed to be on the panel. The National Institute of Health should have had the ethics to say, no, you're automatically disqualified because you're being paid by the drug company. We can't qualify you to create new numbers again over here because that is a conflict of interest and you might not be making the best decision, right? There's that possibility. People are influenced, definitely influenced by money. So the drug industry welcomed the new treatment guidelines. So these were new treatment guidelines. This is, again, what created prehypertension. So what's prehypertension? They took the range of 130 to 139 on the top, and they said from now on, this is prehypertension. Okay, and then they said that you should start medicine in this range now, right? So what that really did is it took the quantity of people who had real high blood pressure, right, who really truly had a problem, which, you know, in the U.S. is about 1/3 of the adult population, and it increased it to almost half of the population. So now, what does that do to the bottom line of a pharmaceutical company? When you change you change the playing field, right? Because we're not saying people are really sicker here, we're just we're medicinalizing a normal range, right? And we're doing it under the influence definitely under the influence of pharmacy, right? And so here's what it did. Last year, patients and their insurance companies spent $16.3 billion for blood pressure pills, which was an amount that was $3 billion higher from 5 years earlier as a result of this guideline. In essence, this guideline, which was influenced by doctors who were being paid by pharmaceutical companies, increased pharmaceutical revenue $3 billion. That's a lot of money. I mean, how can you say that it's not an influence? Anyway, it's a conflict of interest, a huge conflict of interest, and you should be aware of these types of conflicts of interest, and you should bring them up with your doctor. You should converse about these conflicts of interests with your doctor because your doctor oftentimes doesn't even know that these conflicts are there. He's just following a guideline. And here's another example of that. So this was published in the Journal of General Family Medicine. This is just a few years old. Overdiagnosis or not, the 2017 ACC-AHA high blood pressure clinical practice guidelines. So in essence, again, groups of doctors got together and they said, we're going to change the guidelines on what is high blood pressure and what is not. Again, so in this case, American Heart Association, American College of Cardiology, and 9 other professional organizations issued a new hypertension clinical practice guideline. Now, these are guidelines. These are basically, think of these as pamphlets that they're forwarding on to all the other doctors to say, this is what we recommend as a professional association that you do with your patients. And again, as I read this to you, so this was November 2017, which has lowered the hypertension threshold to 130/80. So now, again, we said over here, we said this is prehypertension at 130 to 139. Now they're taking it one step further, right? Let's lower the hypertension threshold to 130/80. The American Academy of Family Medicine has decided not to endorse this new guideline for various reasons, including flaws in the development process and a limited additional benefit for lowering or for lower treatment targets. In other words, there's no additional benefit if you start medicine, here versus this 140 or higher number. And so their biggest concern, their major concern, was the intellectual conflict of interest, right? The new threshold would lead to 46% of the U.S. adult population being categorized as having hypertension, while using the previous threshold, that figure would be 32%. Should we call this change as overdiagnosis? In other words, their concern, again, you have groups like the American Heart Association, which is very famous in this country, and American College of Cardiology, and 9 other professional groups were creating new guidelines saying we want to lower blood pressure reference ranges so that people are being called hypertensive even earlier, right? Even though there's huge conflict of interest. And one group, the American Academy of Family Medicine, stood up, thank God, stood up and said, no, we don't endorse that. We believe there's huge conflict of interest and we can't get behind that. However, all that being said, many doctors are already behind that and already following with those guidelines. As a matter of fact, if you have been to the doctor and had your blood pressure in that range and were recommended medicine, just raise your hand, chime into the comments and let me know. So again, there's a huge conflict of interest. The numbers, I always say the goalposts keep changing. So it started out here, but now the goalpost moved to pre here, and then the goalpost moved again to what would in the past be considered very normal blood pressure, now being called high blood pressure. And what that does is it increases the amount of revenue, potential generation of revenue, and the doctors who are making these guidelines have a direct conflict of interest tied to the pharmaceutical industry, and you need to be aware of that. Again, it's important that you understand that. How else are you going to make an intelligent decision if you're faced with high blood pressure and the need to potentially think about medicine? Now, I also want to show you kind of the paradox of this whole situation, which is when you're looking at high blood pressure and you're considering medicine, and I'm going to show you here, if you look at this diagram, if we can zoom in on this. So this chart is just a chart of some of the more common drug-induced nutritional deficiencies, meaning medicines have consequences. When you get put on prescription drugs, many of them have the ability to lower or diminish or cause nutritional deficit. And so you can see here for blood pressure, in the category of blood pressure, there's a few different categories here. One is the diuretics, furosemide, Lasix, hydrochlorothiazide is a type of diuretic. These drugs lower vitamin B1, vitamin B6, and vitamin C. They deplete them. Now remember what I showed you earlier. Vitamin B1 deficiency can cause high blood pressure. Vitamin B6 deficiency, there's studies that show that vitamin B6 can lower blood pressure up to 10 points, in some cases higher, right? And this drug depletes it, right? And then vitamin C. Vitamin C is necessary to form that nitric oxide that we were talking about earlier. That's the substance that allows your blood vessels to dilate so that they don't become too stiff and rigid. So again, these very drugs designed to treat the blood pressure problem deplete nutrients that are critical for the regulation of normal blood pressure. But then you also have these minerals, and these are going to ring a bell: magnesium, calcium, potassium, zinc, and sodium, right? All being depleted. And then over here on the far right, you've got CoQ10, CoQ10, CoQ10. And then you think about that, because as you move through this chart, right, you've got blood pressure medicines, but if you think about it, what other common drugs do people with high blood pressure get put on? One of them is the statins, right? And statins deplete CoQ10. And what else? Diabetic drugs, right? Like glucophage or metformin, right? And that drug depletes CoQ10. And what did we say earlier? That CoQ10 can reduce blood pressure 16 points, right? So here you are, maybe you're on all three of these. It's very rarely that somebody's on blood pressure medicine in a vacuum. It's a combination of the three. And so now you're taking multiple drugs that inhibit CoQ10, that inhibit the minerals that are necessary to regulate blood pressure, and that cause deficiencies of the B vitamins that are also necessary to regulate blood pressure. And so now what happens is you're being treated for a disease, or a disease risk factor, I should say, that leads to a deficit of key essential nutrients that your body needs to regulate that very same condition. So you end up chasing your tail, and actually it's a losing battle because you never catch it. And so it actually can lead to even bigger problems, more problems. As I mentioned earlier, if you're on a blood pressure diuretic and it depletes your B1 deficiency, not only can it contribute to high blood pressure, but it can cause congestive heart failure. B6 deficiency can cause an elevation in homocysteine that increases your risk for a heart attack. It increases your risk for a stroke. Vitamin C deficiency increases your risk for vascular damage. It increases your risk for atherosclerosis. Again, the very cardiovascular diseases the doctors are trying to prevent you from developing through pharmacological intervention create the same diseases through different mechanisms by depleting nutritional status. And that's what puts you in a very serious predicament. And that's why I want you to know this, because you need to be able to have that conversation with your doctor. This is true informed consent, if you will. How many of you have ever been told that the drugs that your doctor wants to put you on deplete nutrients that your body needs to prevent these very diseases? True informed consent would be the doctor sitting down saying, yes, I want to put you on this diuretic, but I think the risk of the diuretic outweighs, or the benefit of the diuretic outweighs the risk of causing these nutritional deficiencies. And now you at least have had an open, honest conversation, and you can make the best decision for yourself. But if you never are privy to this information, you don't even have a basis by which to judge. You're just going in and trusting that your doctor has your best interest, not realizing that he probably doesn't even know this, right? This is information that I can promise you does not get taught in medical school. It doesn't get taught. And it's unfortunate, because there are about 5 textbooks on the topic. They just are not textbooks that are required reading in medicine. So all that being said, hey, don't forget to check out the rest of the series right here. Make sure you hit subscribe below. And as always, thanks for tuning in.